Good afternoon, everybody. I am so happy that my sister classmate, undergraduate classmate, has joined us today. Dr. Kecia Gaither is a double board certified physician and OBGYN and maternal fetal medicine specialist. She holds a master's degree in public health. She is a perinatal consultant and women's health expert. In her current role, Dr. Gaither serves as the Director of Perinatal Services and Director of Maternal Fetal Medicine for New York City Health Plus hospitals in the Bronx. Dr. Gaither is also an Associate Professor of Clinical Obstetrics and Gynecology with Cornell Weill Medicine. Many more things I want to talk about. We're going to touch upon your role when you were appointed by the Governor of New York in that role. But I just wanted to give you a brief little background. And as I said, we're Barnard sisters. So we have graduated in the same graduating class from Barnard College, and happy to see some Barnard sisters in the attendee list. And again, welcome to those names that I'm not familiar with who are joining to hear Dr. Kecia. So Dr. Kecia, well, the first thing is I always like to know is, going to school with people, we're just all into the groove. I knew who the pre-med people were, who the pre-law people were, but we never got to know, or maybe we forgot because it's been so many years. Did you always know that this was the field that you wanted to pursue? When did that spark come? And when did you decide on this particular specialty in medicine?
Well, my mother told me that at the age of 4, I was running around telling people I was going to be a surgeon. So clearly I knew very early on what I wanted to do, that I wanted to be a doctor. When I started out, I did want to go into pediatrics. And when I got into medical school and did my rotation on pediatrics, they put me on the oncology service. So all I saw was little sick children with cancer having chemo. So that really kind of phased me out. And my next rotation after that was OB. And I happened to work with a maternal fetal medicine specialist, Dr. Sharon D. So Dr. Sunderji, if you're out there, you totally inspired me and changed the direction as to what branch of medicine I would go into. So I love maternal fetal medicine. I followed that poor man around, but he taught me so much. And, I ended up doing a 4th-year elective with him. I'm very happy with the field of medicine that I chose, very happy with it. It is something that keeps you on your toes. You deal with a relatively young population. I still have the thrill of seeing a birth that never will change. And I particularly like taking care of women who look like me, particularly in the underserved population where my services are direly needed.
And so can you break down so you graduate from college, you graduate from med school. What does that training after med school look like? How many different facilities were you at? You were at Downstate at one point, correct?
Right. I did my first year of OB at Downstate. So you go to college, you then do 4 years of residency in OBGYN. If you want to subspecialize, it's 2 to 3 years. I did it and got out within the 2 years before they changed it to 3 years for fellowship. Now it's 3 years. But, it's a lot of clinical work, and it's also research involved, with a fellowship in maternal fetal medicine. So I was able to do mine in 2 years, and move forward with that. Mm-hmm.
So we're going to get to all of your public appearances where you get to talk to everyday people. But I want to touch upon first Vice President Harris's December summit on maternal health. And some of the highlights, I'll put the link in the chat with her remarks and the link to the the recording of that. But just some of the highlights from her remarks. This was before, during, and after childbirth, women in our nation are dying at higher rates than any other developed nation in the world. Vice President Harris also pointed out that women are 3 times as likely to die from pregnancy-related complications than white women. Native American women are more than twice as likely to die from pregnancy-related complications as white women. She says, and this is regardless of income level, regardless of education level, Black women and Native women are more likely to die. And there are stories of women who have experienced pain and had their pain dismissed. They've experienced postpartum depression and have had that dismissed. And she boils it down to racial disparity. What has been your experience around some of these highlights that Vice President Harris has brought to our attention? What are some of the realities? Because we hear these numbers all the time, and make it concrete for us.
What she said was absolutely correct. Black women have 3 to 4 times higher perinatal morbidity and mortality than white women. There are a multitude of factors involved in these outcomes. Certainly lack of insurance, lack of access, lack of the ability to get to the physician, childcare issues, immigration issues, substance abuse. But despite all of that, and just like you said, across the whole demographic, you still see it. So whether or not you're rich or poor, you'll see it. Institutionalized racism and bias, I believe, play a huge factor in the outcomes that you see. When we start talking about adverse perinatal outcomes in our community, there's a trinity of underlying medical conditions that are seen predominantly in the Black population. That's obesity, that's hypertension, and that's diabetes, okay? Now, this trinity precludes to a lot of the clinical findings that we see. Now, let me just kind of break it down. There's such a thing called epigenetics. Epigenetics are external forces which cause internal changes. Now, hypertension, hemorrhage, infection are the primary things in the peripartum period that are problematic. Stress induces a lot of changes in the body. Stress produces a hormone called cortisol. Cortisol can impact a number of physiologic changes in your body. For instance, there is a lot of adverse neonatal outcomes, low birth weight babies, preterm labor. Preterm labor is multifaceted as far as its etiology, but one of the more common things that is involved in its occurrence is infection. Stress induces high cortisol. High cortisol, the stress hormone, diminishes your immunologic function, precluding you to infections. So that's one thing. Research has shown that the vaginal microbiome of different ethnicities varies. There are different bacteria, or there's a different microbiome in Black women, which increases their risk of infection in the vagina. This ascending infection gets into the uterus, induces preterm labor. So you've got some inherent physiologic differences in addition to external factors. So that's infection. When we start talking about hemorrhage, stress, can change the manner in which your blood vessels constrict and stop hemorrhage. So if you have external factors like stress, and then let me talk about some of the internal factors. Research is also out there which speaks on the differences in clotting factors that can occur in women of color as opposed to other ethnicities. So you've got stress, and then you've got differences in the way in which you clot. So your increased risk of having a hemorrhagic event. Hypertension is basically, when you break it down, your vessels are tight, okay? Doesn't allow blood and oxygen to go through these tight vessels. There's a condition in pregnancy called preeclampsia. No one really knows what causes preeclampsia. It's felt to be due to an abnormality in the way that the placenta integrates into the uterus when, fertilization first occurs. Nobody really knows, but what we do know is that there's a continuum of preeclampsia. There's a mild type of preeclampsia where your blood pressure gets to be a certain level, you spill a little bit of protein in your urine, you have a little bit of edema of your extremities. Then you get to the severe part where you have seizures, you can have brain herniations, you can have a stroke, heart attack, fluid in the lungs, liver rupture, renal failure, placental abruption, that's where the placenta comes off while the baby is still inside, abnormalities in your clotting, and death. So when we start talking about preeclampsia and tight vessels, stress can induce endothelial or vascular changes. So when we start talking about the external factors of racism and the stressors that constantly are seen among women of color, along with some inherent physiologic changes, I mean, I think you are at a very you're at a very vulnerable stage when you become pregnant and having to deal with these types of things. So what I usually like to tell my patients, if you're thinking about getting pregnant, it's really important that you see your physician before you even get pregnant, such that whatever comorbidities you have, knowing that the trinity, as I call it, of hypertension, obesity, and diabetes kind of preclude to a lot of things. And just kind of get yourself optimized such that when you do become pregnant, these things are optimized and perhaps it can be caught, whatever is going on, at an early stage as opposed to coming in when the disease process has really past the point of no return and a poor outcome occurs. It's important for you to know that, if you feel that your physician or healthcare provider isn't listening to you, there are options. You can go to somebody else. You don't have to sit and take that. So I think that's kind of the best take home that I can kind of give.
So thank you for breaking it down that way. It makes it that much more clear just how overlapping all of these things are. So, and while we might not be able to immediately affect racism or our socioeconomic status, there are some things it sounds like we can do, and it leads me to ask you about before pregnancy, during pregnancy, even after pregnancy and into menopause. On that, what are some real concrete things that we can do to reduce stress and which then affects those biochemical sorts of levels that lead to bad medical outcomes?
I think being Black in America, everybody knows that the playing field is not going to be equitable. So, you know, for many of us of color, the church has always been that place of refuge, that place of healing, that place of community, that place of togetherness. So, you know, if you are involved in any type of faith-based institution, I think that's probably your first go-to. There are support groups all around, should you elect to have that. I think that, you know, involve yourself with things that you like. You know, for me, a stress releaser is come home and do a little aromatherapy, get in a hot tub, listen to some music, and you know, just kind of let myself decompress. For some people, music is it. For other people, you know, dancing or riding your bike or running or swimming, Tai Chi, yoga, you know, acupuncture. Those are all things which can mitigate and decrease the stress. Do you have a support group? You know, what about your girlfriends? You know, shoe shopping always decreases my pressure. So, you know, you have to think about what it is that you wish to do. That's the first thing. Secondly, I think it's really important for you to find a provider who gets you. You know, y'all can see eye to eye. Someone that can speak to you. You know, I talk to my patients like I talk to my girlfriends. You know, I try not very hard not to speak to them in medical leaves. You know, I speak to them like I'm talking to my girlfriend. Girl, let me tell you, this is what you need to do, and this is why you need to do it. You know, I give them, you know, the what, the whys, the how comes, and this is what you can do, and this is why I'm doing X, Y, and Z. So they have an understanding. I'm not just talking down to them, I'm talking with them. So you need to find a physician who you guys see eye to eye, okay? And some of the best ways to find a physician, you know, talk to your girlfriends. Who do they go to? Who does your auntie go to? If you're looking for a provider of color, there's the National Medical Association, you know, which can lead you to physicians of color in your area. So that's another bent. Know that you don't have to stay with a physician that doesn't get you, because, you know, it's all about relationship and how you feel and mentation and so forth and so on. Now, when you talk about Kamala Harris and talking about a lot of the things that she spoke on as far as equity and poor maternal health, I know for a fact that there's some sisters on Capitol Hill, Representative Adams being one of them, who have proposed something called the Momnibus Bill, which addresses a lot of the facets of what potentially is causing adverse perinatal outcomes. So one of the things that I think is important is access to prenatal care, access to genetic screening, which I think is important, and an awareness of the fourth trimester. That's after birth. That's, you know, that fourth trimester is very important. And with a lot of insurances like Medicaid and so forth and so on, initially they were cutting you off after the baby was delivered. But, you know, that fourth trimester is when, you know, stuff happens. You got your postpartum depression, you know, you might have some peripartum cardiomyopathy, you know, or, you
Breastfeeding
know,
issues, trying to
yeah,
get.
you know, stuff just doesn't happen after they cut the umbilical cord. So, you know, I think they addressed certain things, which I'm very happy to see that is being paid attention to, and legislation is happening such that, you know, insurance companies are now paying for things in the fourth trimester, and there is an awareness that, you know, it just doesn't stop once the umbilical cord is cut. Like you have said before, being ignored. You know, it wasn't that far in the past that certain nursing books had within them, you know, talking about how Black people don't have the same pain, they react to pain differently. They have a higher tolerance. So basically, if a Black person is telling you they're in pain, just kind of blow it off because their tolerance is higher. So this is not that, it was not in the far future that this was still being taught in textbooks. So, it's out there and it's ingrained, particularly among some of the older practitioners. It's ingrained within the institutions that we work in. So it's going to take a minute to get rid of this. It's going to take a minute.
So that's if you're lucky enough to actually conceive. I want to use another celebrity as an example to delve into the inequity. So Gabrielle Union's been very frank in both volumes of her memoirs about the difficulty in conceiving. And in the first volume, We're Gonna Need More Wine, there's a chapter called Get Out of My Pussy, basically, right? And she talks about the pressure, number one, of people always asking, when you're getting pregnant, when you get, this whole, pressure. And what they didn't know was that she said she's had 8 or 9 unsuccessful IVF experiences. And it wasn't until later that a different doctor who got her noticed that she had it is called adenomyosis. Am I pronouncing that correctly?
Adenomyosis.
Thank you. Okay, adenomyosis.
Mm-hmm.
And that was what was interfering with her ability to conceive. And it wasn't until that doctor recognized it, gave it language, told her what it was, that a lot of the anxiety around trying to conceive was lessened. And she came to terms with a surrogate. And where do you think there's room for better treatment of Black women in helping Black women to conceive? Is it, and I'm thinking of these, like you said, these ingrained sort of biases. So we're perceived as having a higher tolerance for pain. We're also conceived as, from our history of being easy breeders, And so a lot of times Black women may not be believed or respected in their challenges to conceive. Where in your experience have you seen, what are some of your, I think, best practices, and where do you see the field can do better by Black women in trying to conceive?
Well, if you look historically, at this point, there is a lot of infertility going around. The rate of infertility is increasing. And I think there are a lot of factors involved in that. First of all, I think that your environment plays a big factor in infertility. There's a lot of chemicals being used, a lot of chemicals being put in things that we utilize to hold our food, to drink from. And some of these chemicals are known as endocrine disruptors, okay? And when we start talking about fertility, there is a circuitry between your ovaries, your brain, and if you have these chemical disruptors, that can basically throw your whole hormonal milieu off, okay? So that's one thing that I think you should be aware of. And keep in mind, our food has a lot of hormones in it. The things that we drink from, the plastics have these chemicals that have hormonal disruptors. So that's the first thing you really have to think about. The second thing is Black women have a high incidence incidence of having fibroids. The medical term are leiomyomas. They're muscular tumors of the uterus. There's a genetic basis to it. Nobody knows why it's so predominant in Black women, but that can impede fertility. Okay, that's the third thing. Endometriosis is on the rise. Endometriosis is a condition where basically tissue that lines the uterus gets outside of the uterus and gets implanted in various, parts of your body, particularly in the pelvic area. It causes a lot of inflammation, scarring, and infertility. Gabrielle's condition, adenomyosis, that's abnormal glandular tissue within the uterus itself. That precludes to infertility. PCOS, polycystic ovarian syndrome, another condition that's on the rise, it seems, where basically there's dysfunction of the ovary, and it can preclude to a number of things: obesity, hirsutism. Hirsutism is where you have abnormal hair growing on your face and on your back and breasts and stuff like that. So there seems to be a rise of a lot of these things going on, which preclude to infertility. Now, with that being said, reproductive technologies, as they are, can kind of assist in that. And I think it's important that if you've been trying to have a baby for over a year with no success, it's time for you to go to see the reproductive endocrinologist, okay? Somebody that, will check your hormonal levels, will do a thorough evaluation of your uterus. There are certain tests where they can see whether or not your uterus is patent, whether or not there's function of the fallopian tubes, whether or not it's been damaged, maybe from infection, from surgery. Are your tubes patent? Are they open? They'll do a semen analysis of your partner. Is there anything going on there? You're going to get a full workup. So if you've been trying for a year and ain't nothing happening, it's time to go to the REI guy. Okay, so that's the first thing. The other thing is, our diets, and I'm really kind of a big person that is kind of into holistics to a certain extent. Our diets really have changed from how grandma and grandpa used to eat. My great grandparents ate from the land. They grew their own food. There was no preservatives. There's no sugars added, no chemicals. So it was pure food. And so a lot of the sicknesses and illnesses that we see now, that didn't happen in Big Mama's day, okay? And I think it has a lot to do with what we're eating. So I'm a big proponent of clean eating, meaning let's decrease the meat, particularly the beef that has a lot of hormones, and chickens do too. Let's go more so on, let's have more vegetables and fruits. Cut out the sodas, and let's do some water. I'm a big proponent of doing that. Not only it's better for you from a cardiovascular standpoint, but I don't think you're exposed to a lot of the ingredients that are in the foods that you eat. I'm a big proponent of reading what it is that's in your food. And if it has a whole lot of lettuce to it, forget about it. And going back to the reproductive endocrinologist, reproductive technologies have really come far. So infertility in and of itself is not the doom and gloom end or be all of your ability to have a child. There's the art of having uterine transplants. Say if you've had a hysterectomy and then decided, well, I want to have kids, well, they got uterine transplants out. If you say your tubes are blocked, well, you can do IVF. You can have your eggs retrieved. The semen can be added to the eggs on the outside. The embryo develops, and then they put the embryo in the womb. Okay, that's IVF. There are different versions of IVF. You can have that done. You can have a surrogate. So, as far as science is concerned, the oldest woman thus far that has been able to conceive using reproductive technology is 78 years old. So when you're saying that, you know, we can't have kids after a certain point in time, well, yeah, we can. Yeah, we can. And technology is going to come to a point where, you know, we might be able to have a baby outside of the uterus, because that technology is already here. It's being utilized for animals, and it's only going to be a certain amount of time before it's going to come our way to humans. But the technology is here because they're doing it with sheep.
And that leads me to this. It was an interesting article. I had never heard the term reproductive equity. Now we've talked about reproductive justice, and you know, we just celebrated the 49th anniversary of Roe v. Wade yesterday, Saturday. And so we know what we are more familiar with reproductive justice in allowing women to make decisions about their bodies and, you know, when to have a child. But I was reading this article on reproductive equity, and it was about the male partner in the equation having more, for lack of a better term, shouldering more of the responsibility. So I want to just point out this article from Madame Noir, and I will put the link in the chat. This article on reproductive equity. Black women are 2.5 times more likely than white women to face an unintended pregnancy, according to the National Library of Medicine. According to the CDC, the most common forms of contraception in recent years for women are female sterilization, otherwise known as tubal ligation. And the Journal of Urology says that 14.1% of white men have undergone vasectomies, while only 3.7% of Black men have. So in the opposite side of deciding when to get pregnant or how not to get pregnant, reproductive equity would require men, or would encourage men, to be more involved in that decision, so that a lot of the procedures that seem overly invasive to women, so that the woman is not shouldering that burden, whatever that is. And so this idea that vasectomies are less invasive than procedures that might be done to women, tubal ligation or whatever, to prevent pregnancy, that vasectomies, because they're inpatient, according to this article, the recovery time is much less. It can be reversed if the decision later on down the line to have children is made. Where do you see more room for men? And you mentioned the whole uterine transplant thing. There was talk about, let's transplant uterus in a man so that the men can also carry children.
That won't happen.
Without going to that degree, have you seen more men becoming equally involved in this process, whether it's getting pregnant or preventing pregnancy? In your practice, have you seen more men taking on more responsibility or more involvement in this whole process?
That would be a resounding no. You know, when you start talking about clipping testicles, you know, for the most part, it's a rare man that will even want to talk about vasectomy. So the answer to that would be no. I have not seen that. I mean, you know, and keep in mind the history of you know, demascularization of the Black man, either through actions, you know, through interactions, or literally with lynching and, you know, castration. So, you know, I think that is not something that most Black men are going to even think about. That's just my opinion.
There's a whole arena for more exploration of racial bias and disparity with men's reproductive health also.
Well, I really wonder, I mean, and I really can't answer this intelligently, are those options ever presented to the man and presented in a way where they, they really understand, well, no, we're not going to be cutting your testicles off, but, is it explained to them in a manner that doesn't horrify? So are they even given that option? Does that even come up? So I can't answer that because, I don't know. I know that the fact of the matter is, as far as prostate cancer, it's highest in men of color. So, for Black men to even go and get their prostate checked, that's problematic. So to even discuss having vasectomy, I just can't see that being accepted as an option for birth control readily.
Do you see that there is an increase in organizations, or whether it's government funded projects that can help advocate for Black women?
Do I see an increase in awareness? Yes. Certainly, programs such as this, I do see that there is an increase. I do. I do think that there is an awareness because, patients come with questions and so forth and so on. So it's out there. You can Google stuff. You can, a lot of healthcare organizations have, different conferences or different health fairs. So, the information is out there. There is an increase in awareness. I think personally, I really think that outcomes are really predicated based on who your provider is. A lot of times in communities of color, the best physicians aren't recruited because either of where it is or the finances that are involved. You don't necessarily get the best physicians coming into communities of color. So some of the outcomes that you do see, I can say, can be based on the particular provider that you may have. With that being said, I think that, one of the first things that you should be cognizant of is who your provider is. Again, referrals based on who your auntie goes to, who your mama goes to, who your girlfriend goes to, that's very important. That word of mouth, as far as who you should go to. I personally think that physicians of color see you. There's a shared experience. I do think that. I mean, there's data out that, preterm Black babies do better when they're cared for by Black neonatologists. I mean, the data is there. So I just think that it's very important for you to be prudent and diligent in who you choose as your provider. And for an OB, again, I think that word of mouth is invaluable.
Let's take the whole trajectory of a woman's life. What are the best practices that we can adopt for our reproductive health? What can we do? What should we know in each of those stages to best
Well,
care for our own health?
well, I think, coming up as a little girl, I think there should be some frank discussions on um, your body and utilizing language that is pertinent. Your vagina is your vagina. It's not your poo-poo. Um, your breasts are breasts. They're not your tatas. There should be some real talk. That's the first thing. I think that when your daughter has her first cycle, that might lend a trip to the physician, just to make sure everything has developed normally. Um, there's something called Tanner stages of female's development, and you look at pubic hair, axillary hair, and breast development. Has she developed accordingly? So, when you have that first period, I think it's important to take to the doctor. When you think that there's some sexual activity going on, have that discussion about sexually transmitted diseases and show pictures, that kind of serves as a deterrent to some of the things that may happen when you are having unprotected sex. Visualization is very important, particularly when we're talking about gonorrhea, chlamydia, and herpes, HIV, hepatitis B, trichomoniasis, those are all things that your daughter coming up should know about. And a visit to the OBGYN to get some birth control is important. When you start thinking about you want to have a baby, before you even get pregnant, go to your doctor. Ensure that whatever underlying health conditions you have are optimized before you even get pregnant, and start taking a prenatal vitamin with folic acid in it. Folic acid is very helpful for brain development. So, you want to make sure that you're tanked up from a nutritional standpoint. Vitamin D is also a very important vitamin for people of color. Vitamin D is made in the skin in conjunction with sunlight. For people of color, melanin inhibits its production. So by definition, most of the people of color are deficient in vitamin D. Vitamin D is important in a lot of things: in mentation, depression. It's important for your cardiovascular health, your bone health. During pregnancy, it's very important for your baby's bone development. It decreases the risk of preterm labor. And most importantly, for all of us, regardless of whether we're pregnant or not, regardless of whether we're male or female, vitamin D boosts immunologic competency. And we're in the time of COVID, so we need all of the immune competence that we can get, and vitamin D is a very inexpensive way to boost your immune system. So, you get pregnant, take vitamin D, you're good. When you start getting, as you're going forward along the continuum of life, it's important that you get your mammograms, you get your PAPs, you get evaluated for colon cancer, when you get to be around 50, so all of these maintenance of things are important. If you have a history of high hypertension, and or if you've had preeclampsia at the time when you were pregnant, those two things can impact your heart. And I don't think a lot of people know that preeclampsia damages your heart. So I think you need to have yearly cardiovascular visits to ensure that you have good heart health, and that, whatever damage might have been done from your pregnancy with preeclampsia, it's recognized and treated accordingly so it doesn't progress. I think that your diet, I'm a big proponent of diet and increasing the vegetables and fruits and decreasing the meat consumption is really important. So when we're going along a continuum, just being cognizant of what you're putting in your body, making sure you're having those visits and those, points of breast health, cervical health, colon screening, all of those things are really important. It just takes a doctor's visit.
Thank you. So I want to give people a chance to shoot some questions out. So if anyone has a question, if you can raise your hand, and I guess you can, if you can't unmute yourself, then I'll unmute you. But since we don't have an unwieldy crowd, anybody with a question can just unmute themselves and ask away.
Off the bat, I really don't. That's certainly something I would have to research and get back to you on that.
When you mentioned PAP and colon screenings, the new timetables have spaced them out more than they were before. Should we be concerned and push for more frequent screenings? A lot of these, and even the blood pressure thresholds have changed.
Yeah, blood pressure is 130 over 80 and above.
Right, it's gone up, and I'm like,
which is a good thing. It's gone down because it used to be 140 over 90, now it's 130 over 80. So I think that's a good thing.
Okay,
for
so
blood pressure.
As far as these screenings and changing guidelines, not only is it a good thing and should we be advocating for more regular screenings, but what might be behind the changes?
I personally don't particularly care for the spacing out of pap smears and breast exams. I think that the spacing out is probably related to money. It's kind of what I think.
Hey, I'll say it, because I'm like, y'all just don't care if we die, do you?
Yeah.
So yeah. So you feel that we should be advocating to do annual,
particularly if there's a family history of breast cancer or any type of female genital tract issues of colon cancer. I personally don't like that they've spaced it out, and I just think that there's a financial basis as a rationale.
Okay, so you heard it here.
So I see a question from somebody I know, Michelle.
Yes.
Are there any changes being observed in terms of the number of BIPOCs going into medicine? The pipeline, that's what it's called. The pipeline of getting people of color into medicine is narrow. I think that there are a number of mitigating factors against people of color getting into medicine. Let me just say one thing for anybody that's listening that has kids or relatives or somebody that they know that wants to get into medicine. I have a friend named Dr. Lynn Holden. She has a great organization called Mentoring in Medicine. And what she has addressed is the pipeline. She gets kids when they're in grade school, if they have an interest in medicine or science, and she guides them, into the pathway of how you go about doing that through various programs, through scholarships and so forth and so on. So Mentoring in Medicine, Dr. Lynn Holden. So let me just say that. There are a lot of roadblocks for getting people of color, particularly Black males, into the pipeline. There's a lack of knowledge about it. There's a lack of knowledge about how to get monies to finance it. There's a lack of knowledge as far as what programs, preparatory programs that you can get involved with in order to enhance your ability to get into medicine. For any kid that's interested in medicine, there's an organization, National Medical Association. National Medical Association has a student branch, Student National Medical Association. I think it's important for kids to know about that, kids of color, because by getting in at such a young age, you're not only within a group of students that are your cohort that have the same interests, but you're also exposed to, the adults, the physicians from all over the country who look like you, who can guide and mentor you accordingly. So I think that that's an important thing to do, because, just to be able to get into medical school and go through it, that's a whole game that I don't think a lot of people are aware of, that there's a certain reality that will be met with. And you need to be able to have somebody to guide you. You also need to have some resilience and some internal fortitude as a person of color navigating the medical playing field, because it's not going to be equitable. It's not an equitable playing field. And there's a lot of potholes and, things that people can do to put obstacles in your pathway. I'm glad you got Lynn's information. So that's really, she's done a really good job with that. The pipeline is narrow for us, and it's important for us to know how to navigate it, because it's not an easy path at all. It's not.
What is your take on the HPV vaccine? And as far as, safety, is it, do you consider it required or necessary or optional, et cetera?
I have mixed thoughts on that, to be honest with you. Cervical cancer is one of the most preventable cancers there are out there, simply because Pap smear screens you for it. And HPV, or human papillomavirus, has been noted to be, there's certain strains of it associated with the development of cervical cancer. So with that being said, I understand the science of trying to prevent HPV from being, trying to prevent you from getting HPV. So I get that. But there have been some side effects from this vaccine. So I'm torn on it, and I'll just leave it at that.
Now, and that's, I appreciate you just stating your ambivalence about it, because it actually helps people who, regular people like me who are ambivalent about it. Mm-hmm. It helps people feel that we're not being paranoid, that
no.
There are things to ask about it. So thank you.
I mean, when it first came out, I was looking at the commercials, and I'm thinking to myself, so what you trying to say? We the only ones that's having sex and getting HPV? I mean, what you trying to say? So that was my thought. But I mean, I understand the biology of it. Yeah, I get that strains of HPV, are associated with cervical cancer. So I get trying to prevent that. But, there's some side effects from that. So rarely. That's a rare question. And when on the rare occasions that I have had that question posed to me, I ask them, are they involved in a faith-based organization? And if they are, then I suggest that the men of the church, if there's no father in the house, have a discourse with them.
You have been on, morning shows, news programs, sharing information. Are you asked to Nasa's point, are you asked by organizations that serve young people to come speak? And where can we help with that? Because I'm on social media a lot. I'll be, you know what? You need to call Dr. Kecia, and I'm going to put your website in the chat. But have you been asked by what sorts of organizations ask you the most to speak?
Wow.
And where do you want to speak?
It's a little bit of everything. Churches, sorority organizations, health fairs, other OBGYN programs, or other programs, within medicine. And, and then there's the big boys, the BBC, CNN, parents, so it has been a progression, and I'm really happy that everybody, reaches out from all walks of life, from all demographics, from all, just everybody globally. I mean, it blew my mind, a couple of months ago when the BBC contacted me to give commentary. I'm like, wow, Kecia. So obviously somebody listening, they're calling you from across the water. So I'm very happy that people are engaged, people listen, people want to hear what I have to say. So I feel very blessed to be able to share knowledge, because knowledge is power. And I think that women should be empowered to know about the health. The women in the household direct the health of the family. And I think that, particularly when you're pregnant, I mean, that's the next generation. So and that's precious. So I think that anything that I can do to make it happen in a positive manner and have good outcomes, I think I've done what I was supposed to do, and the reason why I was put here.
What is that one bit of sage advice that you think trumps all others? What would you like Black women to know the most?
Well, it'll probably be a couple. One, preconceptual evaluations with prenatal vitamins and vitamin D. I can't emphasize that enough. Two, find yourself a physician where, y'all see eye to eye. And three, go get your COVID vaccination, because, people are dying needlessly without being vaccinated. And that doesn't make any sense.
Awesome.